Hello, this is Dr. Hochman. I'm the medical matchmaker. I help doctors find the best jobs where you can really enjoy practicing medicine. And I help through every step of the way. So, helping out with resumes. I'll help prepare for interviews, debrief after interviews, contract negotiations, the whole deal. And I am so excited to introduce our guest to you today. Not only because I love taking care of physicians and I love helping physicians and I love helping my patients. I still practice medicine. But this is a very exciting guest this is someone who inspires me. This is someone who I admire so much for his brain, his incredible brain that works another next level. And he cares. There are times that he's just so compassionate and caring and wonderful. And so, here he is. Let me bring on Dr. Daniel Hochman. And Dr. Hochman, thank you for joining the show today.
Pleasure being on.
And I'll remind you all, this is a live interview. So if you have any questions about addiction, please feel free to ask, whether this is, as a physician, how to help your patients, or just something you're curious about. Please go ahead and ask Dr. Hochman. So Dr. Daniel Hochman is a psychiatrist. He does a lot of work in therapy, doing very deep therapy with patients, and really in addiction. So, the other kind of very cool thing that Daniel has done is he has created an online evidence-based addiction recovery program. And the cool thing is that I think, you had done this, Daniel, before online was a thing. You were really quite a trailblazer, so it's been around for quite a while. What was it that led you to create this, and what made you think, well, let me do this thing online when really no one else was doing that at the time?
I like doing things very efficiently and sort of no nonsense. So that's sort of a philosophy I have in general. And so with this, it was to me just such an obvious, easy way of there's so many people with addiction, and almost none of them encounter very good evidence-based strategies to do anything about it. And so why not put that in a form where you can reach anybody, who's suffering, and those people can access it very easily. And then as I started thinking about doing that, you realize that there's particular problems in the addiction field that make it even harder than mental health alone for people to access. So like there's stigma, privacy issues, time, and all kinds of things attached with entering addiction treatment. So it was a really, really good natural fit for all of that.
So it can be done anywhere, at any time, anywhere in the world, right? And cost was another huge barrier, and something that really gets in the way of a lot of people getting great care. So what is it about the program? So we know we can do it anytime, anywhere. And I'll add to this, it's really extensive. I mean, your program it's hardcore. I mean, that's if you spend, I think we had said, if you spend 30 minutes a day, it takes 6 months. Is that right? To go through?
Yeah, that is right. So yeah, and I usually recommend people spend almost an hour on it per weekday, and then it would take around 3 months to get through. Um, so that's one of the first things to usually work through. People are used to online things being more of a gimmick. I do get consulted for different like mental health apps and things like that, and they're usually pretty crap. They're just gimmick versions and tracking things, and there's no real utility or function or evidence for it. It's just garbage in, garbage out, and people just feel good about it because it's just kind of a latest, greatest bunch of things to click. But this is one of the things I really cared about. So self recovery is actually not an app. Not that I'm proud or not of that, but it is a program. So when people enter, they're actually accessing a complete curriculum. And there's people who have been through rehab multiple times who then do this thinking, it's just going to be some gimmick. And they're encountering things, realizing that everything they had done before fits in one or two very, very small categories within the context of a much larger curriculum that can exist. So it's a very complete curriculum.
So, one of the things about this curriculum, just kind of going to the very, very, very basics is just the definition of addiction. How do you define addiction?
Uh, I'm glad you asked because that's one of the problems I find with the field itself is the definition that most people go by is that there's some compulsive use and that the use is causing a lot of destruction and harms. And that's a very basic and safe enough definition to have, but it doesn't explain psychologically what's happening. So it's not a definition that necessarily helps people understand why they do what they do. Why am I harming myself despite the fact that I know better? So I define it as seeking something outside of yourself to escape some intolerable state. And that could be full on depression, PTSD, trauma, and and it actually usually is something more subtle, which is just like a challenged upbringing, not being happy with where you are in life, being burnt out, or being bored with life, or not finding much meaning. So those are all states that are hard to reconcile and process. And so we look for ways to escape those feelings. And I don't like to get caught up in then, well, if you have that subtle of a definition, and if you're turning to shopping or porn or something, or you drink but not you don't get DUIs and no one's getting you into trouble for it, that doesn't matter to me. What matters to me is psychologically what our relationship to objects are. So if we're using an object to get through bad feelings that we have, then that entails doing something about that process, regardless of what the substance is or the behavior or how much trouble you've gotten into.
And something interesting about your program is, it really because it gets to that underlying psychological reason behind the addiction. You have people in there who are addicted to everything from heroin to food to gambling to alcohol. I mean, it really gets to that underlying reason why anyone has an addiction.
Yeah, and that's really important to me. I think people who have severe addictions to hard substances can more easily admit to themselves that something's wrong, and the treatment centers or people will more easily recognize what's happening. Um, but we're failing all the kinds of people who are in and out of addiction sorts of processes, depending on how bad the week is. So, it's up and down. Or we're also failing people who, yeah, have addiction to, we call process or behavioral addiction. So, yeah, lots of people are using self recovery for things like food and porn, and they're ashamed to present somewhere, not even just because, it's embarrassing, but it's even more embarrassing when you go to a treatment and you're the only one there for food and everyone else is addicted to heroin. You then are getting shamed even in the setting of getting your addiction treated. So I love that the program lets people just do this privately, so they don't have to worry about trying to sort of keep up or be compared with other people's addictions.
Yeah, that's so powerful. And I kind of want to just put a plug in. I think, when you had created the program years ago, um, I went through it and edited it and, kind of helped with it. And it changed me as a person. I've said this to so many people because it really does go through that just who you are as a human being. And really, I was forced to ask myself certain questions. I wasn't even trying to do it. I was just trying to go through and edit and make sure it made sense. And it really was, I mean, it literally changed my life. I don't think I would be who I am today had I not edited this program for you. And I'm grateful for it. I love the program. So,
Well, thanks. Yeah, and that's the whole idea is treating addiction is not really treating addiction. You're treating everything going on that's led a person to behave the way they behave. And so that's how I know when good addiction treatment is being done is when you see all these collateral effects. And so you're not just treating it, not just thinking of it like, well, if I stop drinking, I'm going to clean up these other areas of my life too. But it's more actually the other way around. When you become the kind of person you want to be, and you're proud of yourself and you conduct yourself in ways that you're living this higher form of existence, then addiction is not necessary. We're not trying to fix the way we feel if we feel better. So the very source of addiction still always begins with some discomfort and some emotion or some state that we don't like being in. And so you could imagine, all the effects of getting that in order, where, yeah, there's people go through it and they didn't care about their caffeine intake, but, they reduced, or they didn't care about, how much they were shopping, but that also gets in order. All kinds of other things get cleaned up.
Yeah, that's very cool. Tell us the data. Tell us the data. What are your numbers?
Yeah. So the addiction industry at large has effect rates between 5 and 10%. Most people will say it's around 8. So that's like a full-on rehab. So if you go away for 1 to 3 months, the success rate over time is still below 10%. Our success rate is measured from pre and post program, and that's at 76%. So 76% of participants reach a full effect, and then still more would have some effect. So our rates of success are many times higher than the industry average, and the enrollment cost is $99 a month instead of anywhere from 15 to 90 grand. So so we're far under 1% of the cost, and achieving far better results. And that's what I'm most proud of. Like I said, the draw for me is that we're doing this jerry-rig style. It's just, there's so much that people can learn so much more easily than they're encountering it right now.
And this is selfrecovery.org for anyone wondering. Um, but at the rehabs, it takes you out of that environment that is your trigger. So wouldn't that be helpful? You know, if self-recovery is done from home, you're not getting out of that state that's really triggering you to be addicted.
Yeah. So there's a lot of notes to make. I mean, one, in general, for people, the initial phase of treatment will be, you'll see quicker traction if you're removed from your environment. So that part is very much true. But of course, the problem is, well, what happens after that? And a lot of treatment centers, I will commend them. They're good about this disposition plan. And so you're, say, living in Austin and your whole world is there and your dealer's there, or the triggers are there, or your ex is there, or whatever. And so, they will do a good job sometimes of, then why not move to where you have this one good family member in Kansas City and you go, get treatment there, start a new life. But yeah, in general, not only do we need to be mindful of the triggers there, but ultimately, we have to take responsibility, not just for our actions, but just the way that we conduct ourselves in general, our whole psychology. And so, if you're going back to like the way I like to define addiction, because it's not just removing the substance and then we don't use and we make better choices because we're not using anymore. If your fundamental process is still to use something else to change your internal state, you go to Kansas City and you're going to find something to change your state. And you will end up finding people to get things to do that. And so there's fundamentally nothing changed over time, which is why the recidivism is just so high. So the relapse rates are, like you said, well over 90% coming out of even a full deluxe treatment. And that's why, in my view, they're not doing enough to change the underlying psychology of how they relate to their distress.
So you get to go through the program and practice it while you're doing in the environment that you would be living in all the
That's the
time.
whole idea, and that is always the most powerful. I mean, if you can't pass that test, then and that's not enough for me or my patients or my enrollees. So you have to be able to do well wherever you move yourself in space and time, and it's on you. That's a responsibility, and there's a lot of meaning in owning that responsibility. It is true there'd be a lot of triggers here and there, but it's not that we need to be masochistic and overly expose ourselves to toxic people or situations. That would still, of course, be allowed, right? So if you're in Austin and you're having a hell of a time, you can still befriend different people. You can still shade more towards this way than that way. You could move apartments or homes. You can still make these changes, right? But in generally, when we leave a certain setting, we're not only leaving the triggers, but we're often leaving very good supports or good family members or good relationships or good activities. And so, um, there's a lot that we want to keep usually as well. But yeah, we ultimately need to redefine the way we're conducting ourselves and ideas and beliefs and value systems that we're operating out of. And so those should change slowly. Those shouldn't be changed in dramatic form, although that usually appeals to people, to go to rehab and make these sweeping changes. But I think even people who haven't been exposed to the field already know that that's bogus, right? You cannot just make these sweeping proclamations that you'll be healthier. That just doesn't endure. But we all know that from diets, from exercise, from anything. It just doesn't work that way. And so something that's this compulsive feeling is even harder. So it's generally a very slow, methodical shifting of how we behave, and that being done, testing ourselves in our own environment is 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 where it needs to occur.
So let's shift over a little bit for the physicians watching who have patients with addiction, which I would say is all of us. What would you say? I think as far as just a quick visit, so especially in primary care, we typically have a short visit where they want to discuss every body system. So we don't have a whole lot of time. What would you say for us as physicians who are, treating patients who have addiction? And maybe wanna do something about it in the small amount of time that we have.
Uh, so lots of things to say. One is a lot of physicians believe, and this is confirmed by surveys, not only my suspicions. Um, Doctors believe in general that there's not much that can be done to help addiction, and so if you don't believe that treatments are going to be very effective for them, and that they're just kind of once an addict, always an addict, then you're unlikely to do anything. Why go through the pain of a difficult conversation and challenge the patient if it's not going to be helpful anyway? So one thing is to understand that there are effective modalities for treatment, not only with self recovery, of course. I mean, I generally recommend that people just get into very good outpatient care. That is where the best results are. So just reaching a very good outpatient setting can make a profound impact on someone's life with addiction. So first is actually looking into things or believing that there is effective treatment. If you believe that, then you're more likely to try and get someone into treatment, and that would be the goal of care, for anybody that's not a psychiatrist or therapist. So unless you're really ready to learn and practice and be supervised and do that, most likely these are handoffs, right? So they're referrals and handoffs and arranging. And so, to do that doesn't require that you lift the whole mountain or start to understand their whole complex situation and all of their life's burdens. It's just enough to recognize that they're a little more stressed than usual. Their blood pressures that have gone up for no good reason. They have reflux that's not very explainable. Their sleep is getting poorer. They have sleep apnea for no good reason. So there's a lot of tip offs for high HDL for no real lifestyle reason. There's a lot of tip offs that we can get that tell us something's happening, or we just know because we know the patient well, or they reveal to us that there's something going on. If you realize what's going on, you first have to just sort of check in with yourself. Am I afraid to bring things up with them? Or am I comfortable and I just don't know what to say or what to do?
Yeah. That HDL thing I wanna come back to because I actually was just discussing it with a patient the other day who happened to have a high HDL, and that was the tip off.
Oh, really?
Um, that HDL, which is something I learned from you, the HDL number is 60. Above 60 is typically what we think should be tipping us off, and, do you know what that correlates to alcohol-wise, how much they're drinking?
I don't think that's ever been borne out. Like, I don't think that there's any good charts on, what amount equates to what. I'd say more just that it's a mismatch. You kind of eyeball someone and say, okay, I don't think that's because you're eating a bunch of nuts and working out all the time. So that's more the typical.
Okay, so kind of knowing when to ask about it and what to do. And when you say outpatient handoffs, you're talking psychiatry, therapy. What about like PHP, IOP, which is intensive outpatient program, and what's
and,
PHP
and
stand for?
partial hospital.
Partial
Um,
hospital.
yeah, all of the above, right? So the more dire, right, the more acute, then you might think more about PHP. If it's kind of a very slow moving, safe setting, yeah, then outpatient therapy. Um, and then it's a more nuanced decision, if they're going to be interested in medications or not. That might be something in primary care that you already know or interested in learning, just a few sort of medications to get comfortable with. And if not, yeah, then that'd be important to have them see a prescriber, not just a therapist. So psychiatrists should generally be very comfortable with those kinds of medications.
Which medications do you think are appropriate for a primary care physician to be prescribing? Assuming we haven't done it before, is there something that you say, hey, this is such an easy medication to prescribe? It's so effective. Why not give it a try?
Yeah, so just a couple kind of weapons to get equipped with would be naltrexone. So we don't have to dive into the complete lesson here, but naltrexone 50 milligrams is generally very, very safe, well tolerated, and does help with. That's a good one because it helps with all kinds of addiction. So we use it for alcohol, opiates, and then even behaviors as well. That's not on label, but still we use it for eating and all kinds of things. Um, and yeah, and so it's very safe. And then the other one that people get a little more scared to use, but is even um, more helpful, would be antabuse, so disulfiram. And that, for anybody, just to refresh, but I think that's one that every physician's heard of. But that will make you react very quickly and badly to when you do drink. So this one's only for alcohol, and it sounds very punitive. And I think a lot of doctors are afraid to prescribe something that sounds like it's punishing. But there are ways to prescribe it that are very benevolent. So describing it to them as like calling upon their better selves, where they take it in the morning and they're enacting that part of their character for the rest of the day with no choice now. They've taken it, and then if they have a really bad day, they just can't change their mind anymore. So we're helping draw out the best part of their character, and that's not punishing at all. I mean, that's just facilitating the best person that they want to be. Um, and then the other one that is even sort of more foreign to a lot of doctors and feels more scary is buprenorphine, which a lot of people know the trade name Suboxone. That's when it's a combined product. But buprenorphine is an opiate, but it's for harm reduction. So instead of using painkillers, heroin, fentanyl, you're using an oral medication and you're taking it daily, and you cannot hurt yourself on it. So it saves a lot of lives for people that have risky use, either regularly or even infrequently. So it prevents people from overdosing
And as a
entirely.
physician, that is such a rewarding medication. And I remember years ago you telling me how rewarding it is to prescribe buprenorphine for patients. And not quite understanding, but I had the X waiver to be able to do that. And at one point, that was something that I was doing, and I couldn't agree more. It's life changing for so many people, and really something that is easy to prescribe. It's very hard to go wrong with it. And extremely rewarding and so needed. So I want to put a plug out for any doctor watching this to go get your X waiver. It's awesome. It's a great medication. Um,
Yeah,
can
and
you
the
talk?
government's done a good job of removing a lot of those barriers, so it's not as much of a hassle to prescribe anymore. Um, but yeah, thanks for asking about that and plugging for it, because in the context of medications and procedures that us physicians are, you know, learn and practice and keep up with, these are so easy, like they really are. When I use them, that's my brain is not even working. It's so easy to prescribe these and and explain the risks and benefits to them. So we can't do all that quickly right now, but just know, I mean, if you wanted to look into those, it's very easy to prescribe. It's really not that tricky.
Yeah, and, I don't know if they still do it, maybe you know, but there was a training course we had to do when we got the X waiver, and it was thorough. I mean, I came out of that training knowing exactly what to do, and I think for, those of us more seasoned physicians, we kinda get stuck in our ways sometimes, and learning something entirely new can be difficult, but this was really, really easy.
Yeah. Mm.
So, thank you for doing that for your patients. Um All right, I have a question for you, and if anyone is watching live, please feel free to post any questions, and even if you're watching afterwards, post a question. I will make sure Dr. Daniel Hochman, answers them for you. Um, Nothing personal. He is a doctor, but he's not your doctor. Before we jump off, for the physicians watching, perhaps they're kind of coming to the end of their residency or fellowship. Is there anything you would want to say to them, and or if you could go back in time to when you were finishing your training, what would you tell yourself, or what would you tell these trainees?
Maybe I'll start with what I didn't like being told, and then what I wish I had. Um, I didn't like being told when I started. Um, so I took a job straight out of residency because I wanted the security of a position and amidst a move, and I don't regret that. But then I wanted to get into my own private practice and practice in a way that felt true to me, and in a way that I believed would be the most helpful for patients. And I was told straight up by a very, very respectable sort of leader, a psychiatrist, saying, you won't be able to make a living doing it that way. So in this case specifically, I mean, doing therapy with your patients, that, I'd still need a model where I'm primarily doing med management, where I flex into therapy sort of as I can, instead of the other way around, where I'm only taking patients to do therapy. So I was told by multiple people that just won't work, and I'm glad that I'm a little too stubborn, and I, I I was cautious about it, but nevertheless I did believe in what I wanted to do, and so it would have been really nice to have extra reassurance that whatever you do choose to do, you'll find a way to make it work. So there were so many other buffers or ways I could have pivoted or added on other kinds of types of treatments, types of patients, had it been more difficult. So where there's a will, there's a way. If you love just a particular kind of patient, particular set of symptoms, a particular um, procedure and treatment or anything, like, do what you're going to really enjoy and make sure that you're practicing in a way that feels true to you and matches with what you think is really helpful for patients. Um, and sure, you have to make some compromises. I mean, it's arrogant to think we're going to get it all, but don't give too much up. Don't just take it that you've got to work somewhere and sell your soul or do anything that the world or the hospital system tells you. You just don't have a choice. You're not going to make it. If you don't do X, Y, or Z, you will. There's a lot of patients. There's a lot of ways that people suffer in this world, and and so if you stick with what you really enjoy doing and will be helpful, it will work out. It will sort itself out.
And I'm going to pause there. I think knowing you outside of this interview as well, I would say you really do stick very true to what is important to you, and I really want to emphasize to people watching, you don't have to do what people are telling you. And this has come up a few times, like, forget what people are telling you. Do what you love to do. And because you've stuck to that, you are not burnt out. You come home at the end of the day, you still like what you do. There's no burnout that I see so much and have experienced myself, And that's in large part because you do exactly what you want to do. And no matter what anyone tells, even me, hey, you should do this or you should do that. The answer is no, I don't want to do it that way. And
Mm.
because of that stubbornness, you aren't burnt out. You're still enjoying practicing medicine, and there's really no end in sight. I mean, even when we talk about retirement, part of your retirement plan is to keep seeing patients because you've stayed true to what's important to you.
Yep, that's exactly right. I mean, talking with my patients is really a joy. It's all just fun little puzzles to figure out, and I think they can sense the excitement and curiosity, and then they get to share that, and it becomes a fun process and not, just a really boring one of, managing medications. And so um, it's a joy for me and my patients. And if I love med management, then that would also be more fun, and they might get excited about why they change a certain dose when, but that's not what I like. So yeah, I think we all have the chance to just do what we like, and um, really it'll sort out.
Yeah, and that job you took, right out of residency, it had the potential um, to be just that stopgap. If you loved it, you could have kept doing it, but there was no non-compete. There was no, your exit strategy was kind of built in. Like if you ever needed to leave it, you were good. You could start your practice or join another practice or whatever needed to happen.
Yeah, yeah.
Great. Anything else that you would tell yourself or tell other people before we sign off?
Um, you know, practice what you preach, and there's more in general now, not just for physicians, but make sure you're being the person who you respect and are proud of. So, when you can embody that person, um, yeah, everything is good. Everything's a little more tolerable, everything's more sustainable, and a little more fun. Um, it's still difficult, and life is still a hell of a challenge. But when you're pursuing the kind of life that you believe in, then they're all good challenges, and they're met with meaning and not just another day of hell. Um, so yeah, point yourself towards the most respectable, proud human you can be.
Oh, I love that. Thank you. So selfrecovery.org is the addiction program. And your website, in case anyone watching, wants to refer a patient or be a patient, I guess, what is your website?
It's hochmanhealth.org, so it's Hochman health.com. I apologize, hochmanhealth.com.
Okay, so selfrecovery.org if you or your patients are looking for an online evidence-based addiction recovery program, and your website is hochmanhealth.com. All right. Well, thank you so much for joining us today. It's been amazing. And if anyone watching this is looking for a job, please do contact me. Or, if you need help through the process, my website is www.happydayhealth.co.